So the platform study was conducted in a setting of some confusion, if you will, around what's the optimal way to evaluate stable chest pain patients. Our guidelines have a number of recommendations for exercise ECG, exercise nuclear, exercise echo, or pharmacologic imaging. And then there's a new technology, CT angiography, which has been tested really in the last year in stable chest pain patients against usual care, which showed that it improved some processes of care, but perhaps also increased the number of procedures without showing a benefit on clinical outcomes. So a little bit of a mixed message. And so the question is, if a CT test, you could add functional information to it by calculating a fractional flow reserve, would that remove some of the problems of CT while preserving its benefits in the management of stable chest pain patients? It's a variety of things. We don't have a good handle on patients who may simply be reassured and sent home without any medication or without further testing. In the PROMISE trial, usual care was functional testing of the physician's choice, and that ended up about 2/3 of the time being stress nuclear, about 20% of the time stress echo, and 10% of the time stress ECG. Now there's also a contingent of patients that go direct to the catheterization lab, and that was excluded in the PROMISE trial but was included in the platform trial, and in fact was the primary analysis cohort. But we know they exist because of data from NCDR and other like the VA. We know that a large percentage or proportion of the patients who have a stable elective diagnostic angiogram actually do not have a preceding stress test. And so that's a group of some concern. How can we manage those patients better? Yeah, so in platform, in the primary cohort, which was usual care was to catheterization, about half of those patients had a stress test before and half of them didn't, but all of them went to catheterization. 73% of them did not have obstructive disease by rigorous QCA, which is a little higher number than is by routine site read. Now in the CT followed by selective FFRCT, if there was a lesion arm, 60% of patients had their catheterizations canceled. Very large number. But we had about the same number of revascularizations, which suggested we really didn't miss anybody with significant or high-risk coronary disease. That was the primary endpoint on the trial. What we've reported here today is looking at the longer-term events. So was this safe over a year? And in fact, it was. There's a very low adverse event rate in both arms, and it was equivalent. Was radiation the same? It was absolutely the same. Was quality of life the same? It was the same. The interesting thing is that it was cost savings, and it's actually not a surprise with that percent of people having their tests canceled, that it was up to 30% cheaper, a third cheaper, to pursue the CT-FFR strategy. The other thing we said, we really drilled down on those patients who had their caths canceled. They did fine. There were no adverse events in that group. And I think that's very reassuring that we're not missing anything by not proceeding as planned. I think there's several take-home messages. One is that non-invasive testing that provides both anatomic and functional data is superior than a catheterization in terms of referral and decision-making and going straight to cath. And this was true in patients who were going to cath as their first test or those who had had a preceding stress test. And so that seems to be better for processes of care. Certainly none of us want to have a catheterization if there's no chance of benefit, right? If you don't have disease, you can't benefit from that cath in terms of a revascularization. And we can do it in a very economically attractive way. That's a really good question. In Europe, it's very available. It has been approved by the FDA now about 18 months ago, so in the end of 2014. It is beginning to be covered by private payers, and in the meantime, the company that performs these analyses, HeartFlow, who funded the platform study as a important note, is offering a subscription models to hospitals, and this is very attractive. You don't lose anything by getting the information, and then you become familiar with it. So the more you do, it costs the same amount. A lot of centers are beginning to experiment with that and seeing how it works in their system and in their care flow.